All right, we're going to get started. Good afternoon, everyone, and welcome to today's webinar, Understanding Brain Aneurysms, Perspectives from a Physician and a Patient. Thank you for joining us. My name is Rachel Ishak, and I'm a Community Outreach Specialist at the Brain Injury Alliance of New Jersey. And the Alliance is a nonprofit organization with a mission to provide education, awareness, prevention strategies, advocacy, and support for those who have been affected by brain injury. So I just want to announce some upcoming events that we have. We have our annual walk on September 30th and October 14th in their respective locations. If you're interested in learning more or for registering or donating, please visit our website. You can see that link there. And we also have a new tab on our website that will show you all of the upcoming webinars we have scheduled until February of next year. So you can go on there, see all the upcoming webinars, and actually register for them at this point in time. So I'm going to put the link in the chat, and you can access them as whenever you would like. And the next one we have coming up is post-COVID long hauler symptoms, and that's going to be on October 12th. So just a few housekeeping notes before we begin the webinar. Attendees' microphones have been muted, so if you have any questions at any point during the webinar today, please use the Q&A function. We will get to as many questions as we can at the end of the presentation. And the webinar is being recorded, and it will be available for viewing afterwards on the BIANJ website. So at the end of the webinar, a link for a post-webinar survey will be placed in the chat. We value your feedback, so you are encouraged to complete the survey, and you must complete the survey in order to receive a certificate of attendance. So once you complete that survey, you will automatically receive your certificate of attendance via email. So I'm going to welcome today's presenters. Today we have with us Dr. Gupta and Lamira Clark-White. Dr. Gupta currently serves as the Director of Endovascular and Cerebrovascular Neurosurgery at Rutgers Robert Wood Johnson Medical School. He is also the Director of Rutgers Neurological Disorders in Pregnancy Program and the Director of New Jersey Brain Aneurysm and AVM Program at Robert Wood Johnson University Hospital in New Brunswick. He's also Associate Professor of Neurosurgery at Rutgers RWJ Medical School, and he is the recipient of the prestigious American Heart Association / American Stroke Association Young Investigator of the Year Award for his work on transplantation of neural stem cells and neural progenitor cells in brain for stroke. And his research was awarded top 10 research advances in the world by American Heart Association, American Stroke Association in 2001. And then we have Lamira Clark-White, and she is an Assistant Vice President of Program Management and Co-Chairman of MetLife Diverse Abilities at MetLife. She holds a Bachelor of Science in Computer Science, Business Management, and an MBA in Marketing / International Business from Seton Hall University. She's also PMP certified by the Project Management Institute, and Lamira has received an honorable discharge as Sergeant from the United States Army Reserve. She's an active member in her church, professional and community-based organizations, and she's a trustee on the Brain Injury Alliance of New Jersey's board. So I just want to welcome Dr. Gupta and Lamira. Take it away.
Thank you very much. Lamira, you want to go first? Sorry, I can't hear.
It's up to you. I can go first and give the patient perspective, and you can round it all out. So that's fine. Good afternoon, everyone, and thank you so much for joining, and also thank you for the opportunity to participate on this panel. I'm wearing multiple hats today. In addition to being a survivor of a ruptured brain aneurysm, I'm also one of the 2 co-chairs of the MetLife Diverse Abilities Business Resource Network at MetLife. And since 2013, we have partnered with the Brain Injury Alliance of New Jersey to host annual brain aneurysm awareness lunch and learns. And that's where we provide information, as you're going to hear today from Dr. Gupta, on what a brain aneurysm is, what the signs are, and all types of great information that I wish I had known when I had my aneurysm. Mr. Tom Grady, the Director of Advocacy and Public Affairs for the Brain Injury Alliance of New Jersey has been a great partner with us since the beginning, helping us to identify panelists each year for this event. Dr. Gupta has been one of our special guests in the past as well. So I'd like to welcome my fellow MetLife colleagues across the country for joining us today. And another hat that I'm wearing is, as you heard, I'm a Brain Injury Alliance of New Jersey Board of Trustees member. And the final hat that I'm wearing is I'm a patient of Dr. Gupta's. So I have several hats that I'm wearing here today. So my situation was a little bit different. As you hear, and you probably heard, people saying that they had the worst headache of their lives when they had their aneurysm. And that's how it's normally described. I am the complete opposite. I had no headache at all. And anyone that knows me, my friends and my family would probably say, you know, she always likes to do things different. And so I guess I was somewhat different in that I did not have a headache at all. I was actually having a wonderful week in Washington, D.C. at a conference. It was the culmination of the event that Friday evening. I had gone to a gala and we were having a great time. So I had no symptoms at all. Not that I knew of. So nothing was abnormal for me. And it was midnight on Saturday, February 11th, 2012. And that's when my entire life changed. And what I knew before the clock struck 12 is something of the past. And I have what I call a new normal now since I've had the aneurysm. So as I said, I was at an event, I was on the dance floor having a great time. And then all of a sudden, I said, you know, I need to go back to my room. I was getting a little tired, so I was going to my room. But I heard one of my favorite songs. So I decided, anyone that knows me knows that I love to dance. So I heard a favorite song, and you know what? That song is what actually saved my life. Because had I gone back to my room, I was going back to log on to book travel for work for the upcoming week. And my norm is when I'm tired, I'll log on. And while I'm waiting for the computer to boot up, I usually lay my head down or I just stop and just pause for a second. And had I gone back to my room that evening or that morning to do my normal, then my story would have ended differently. Actually, my story would have ended at that point because there would have been no one there to assist me and I would have gone to sleep. So I'm on the floor. I come to my colleagues, my fellow cohorts at the event. I'm asking, was my face drooping? Because I started to feel my face getting numb and I felt my legs getting a little wobbly. So I said, oh my goodness, you know, I think I'm having a stroke. But then I said, Lamira, look, why would you be having a stroke? You have absolutely no symptoms or you're not subject to have a stroke. So I started questioning and trying to diagnose myself. And again, those that know me know that I have this type A personality and I try and figure out something on my own. So by the time I decided in my mind that someone should call 911, my cohorts had said that they had already dialed 911. So I was taken to a local hospital in Fort Washington, Maryland. And that hospital was a relatively small hospital. But what I do recall happening is the person that was helping me said that I had a brain bleed. They said that the CAT scan showed that there was fluid on the brain. So I had a subarachnoid hemorrhage. That's what was going on. And in my mind, I thought I was clearly speaking as I'm speaking today. And I'm thinking that I'm speaking to everyone around me the same way. What was coming out of my mouth was very jarbled. And again, I couldn't understand why no one could understand me because again, this was all new to me. I had never thought, I had heard of aneurysm. I'd never thought of being someone that was affected by an aneurysm. So I'm struggling to find the right words. And then after a while, the way that I was talking, it ended up, I guess, as I'm beginning to decline, then it was becoming increasingly difficult for me to find the right words. So I was struggling for words. And then I remember hearing them say, we need to get her to Washington Hospital Center in DC. So they were trying to determine whether they should airlift me because at that point I was degrading. My condition was degrading and I was basically dying. So the next time I woke up, I was in Washington Hospital Center. It was within a 24-hour period. I was in Washington Hospital Center, and my family was around me. So I couldn't understand why I was there. Well, why they were there, because they weren't with me the night before, and why I was there. I just recall the last day I was feeling lethargic, I was feeling confused, and I remembered that I was paralyzed from the waist down. So as I woke up and I started to recount what happened, then my family is looking at me very strangely, and I couldn't imagine, why are they looking at me? And the reason why is because the doctors had told them they had done all that they could possibly do for me. They had done a coiling procedure, had gone in through my groin, gone up to, and Dr. Gupta will explain all of the technical pieces of this, but they had gone in through my groin and gone up to my brain and put a coil in. And so I have a coil. And they had at that point basically done all that they could possibly do to save me. And they said that if I woke up, they were not clear how much brain damage had been done. So when I woke up and I'm talking to my family and I said one or two sentences, they're looking to see, well, what can she say next? Does she really remember, or is this all she knows? So they were very surprised, and I'm surprised. So we're saying, well, okay, I'm saying, why are you here? And then they're trying to figure out how much damage has been done. So fast forward a couple of days, then I was doing well. 3 days later, I was sitting in the chair talking to the nurse, and again, I was paralyzed from the waist down, but I could remember and I could talk and I was doing well. And then 3 days later, I'm talking to the nurse and I just kind of glazed over. So I had what's called a vasospasm, and they had to rush me back in again. And I remained in ICU from February 11th until February 29th that year. So that entire month of February in 2012, I vaguely remember anything that had gone on. And once I was stable, then I was able to, a couple of weeks later, go to a step down unit. So I was pressing to come back to Jersey. I was pressing to get home. I wanted to come home and go to physical therapy. I knew I had to go to physical therapy because, again, I couldn't walk. So I wanted to come back home. So I was able to convince them to send me back to New Jersey and allow me to go to Kessler rehab. So I was transported to Kessler in West Orange, New Jersey, and I continued my physical therapy there until March 21st. And so I was determined that I was going to learn to walk again, and I was determined that I was going to reclaim my life because I felt that it had been taken away from me. And at Kessler, I graduated from the wheelchair to the walker to the cane to being able to walk on my own. Now, I haven't gotten back into my 4-inch heels yet, and I don't know if that's ever really going to happen, but I'm just thankful that I can walk and I can do the things that I used to do. So I had what was called drop foot. My foot was just slammed on the floor as I was walking. And occasionally now I still get that. If I'm extremely tired, and then I'll find that my body will just start to shut down a little bit and my foot will slam, and I have to really focus on walking heel toe. And that's really how I learned to walk again, heel toe. So there's some control, and I had a medical device that was helping me guide my foot. So it was a very interesting time. And then you may think that, okay, she's now walking, she's home, and the ordeal is over. No, the ordeal was not over. And because that was medically. Emotionally, I was a wreck. I was a complete mess. So my thoughts were, why me? How could this happen to me? What could I have done differently? What had I done so wrong? Why was I being punished? So I was just, I thought I was a good person, more or less. So I just couldn't imagine what was wrong. So I was frustrated. I was angry. I had lost 20 pounds, and my head had been shaved so that they could put the tubes in so that it could drain, the blood could drain out and the fluid could drain out. So I was just a mess. And one thing that I was terribly afraid to go to sleep, Now, I was not asleep when any of this happened, but I was so afraid to go to sleep. I was afraid that I was going to die if I went to sleep. So along with the medical pieces of it come a lot of emotional pieces too. And, I had thank God, I had a very supportive family. I have supportive friends. And so it helped me when I would go into a depressed state. Um, I was determined again that I'm going to get my life back. So that's what kept me going. So I would push myself to walk. I would push myself to do certain things. And then I said, I want to go back to work. I really do want to go back to work. And everyone was a little afraid of me going back to work because they said you have a very stressful job and, this may happen again. Well, anything could happen again. I could walk out the door today and God forbid a bus come by, but you've got to take chances. So I was so determined that I was going to get my life back. I pushed so that I could get back to work. I pushed through rehab. I pushed my doctors to just say, let me see what I can do. And I felt if I was able to come back here and resume my job and do the things that I normally did, that I could get my life back. So I encouraged my doctors and everyone else to just let me go. Let's see what happens. And fast forward 5 months, it was 5 months and I was able to go back to work. So I came back to work, let go of my pity party because I felt that if I was able to get back to normal, I would be able to just get rid of this pity party and relieve myself of some of these fears. My doctor said to me, go to sleep. You don't have to force yourself to go to sleep because again, I was afraid to go to sleep. She said, when your body gets tired enough, you will fall asleep. So stop torturing yourself, trying to make yourself go to sleep. It'll just happen. So as time went on, I was able to get back. It was hard work. It was self-determination, excellent medical care. And during my transition back here to New Jersey, I realized I could not keep going back and forth to Washington Hospital Center. I had great neurosurgeons there. I had a great staff of doctors there and nurses, but I live here in New Jersey. So I knew I had to establish a relationship here. And I found Dr. Gupta. And, he has been really very supportive and really great. He has tons of patience, but he was able to take me on. And we've established that relationship. And I'm very grateful to him for his support. And I know sometimes I'll come and say, well, I think I have this going on. And he reassures me that everything is okay because annually you have to have tests. And I have the MRA done. He checks to make sure that in addition to the coil, I also have a pipeline. So they had to wait until I got stronger to take me back to DC to do the pipeline. So I have two things going on in my head. And so we have to check annually to ensure that those things are working in good working condition. So again, I got back to work. I was able to drive again. That was one of my things, making sure that I would be able to drive. So I jumped back into all of my activities and just resumed my life. And when I came back to work, there was a business resource network that was being established. There were 5 of us that wanted to focus on different abilities. And that's how MetLife Diverse Abilities came about. And as I said, we started the annual Lunch and Learns talking about aneurysms and how they come about. And so this MetLife Diverse Abilities is to make sure that we champion disability inclusion, we champion awareness, and we host various programs. And the aneurysm Lunch and Learn is one of the many ones that we do. So here it is, 11 years later, and I'm still here. I do have some residual effects from my aneurysm. I've been back and forth to physical therapy. If you know me well, you'll know when I get really tired that certain things happen. Again, my walking, sometimes I might struggle for words depending if I am very tired. So I make sure that I try and I try my best to get as much rest as I can. I know that doesn't always happen. For those of you that know me that are on here probably saying she doesn't sleep probably more than 3 hours a night, but I try to do what I need to do. I try to keep myself healthy. And so I have to have certain screenings. I have to take certain medications and have to go to physical therapy off and on for my foot because my toes really don't move. And one of the side effects is my left side is weaker than my right side. But thanks to God, I am still here and I'm able to do things. I'm able to function because when I look at where other people are, so many people do not make it when they have aneurysms. So many people do not have an opportunity to go through the healing process because they're gone as soon as it happens. So I am grateful for being here. I feel very blessed to be here. And I just want to make sure that the reason why I'm an advocate for things like today's webinar is because I want to make sure that everyone knows as much as possible about aneurysms, when to get help, who, if you know someone else, it could be you that was affected by it, could be someone else. Make sure that people go to the doctor and get the tests they need to get done. So yes, I am very grateful to be here, and it's the medical side, it's the emotional side, it's the physical side, and then there's the long-term getting back to a new normal, because it is a new normal. And that's my story. So thank you all for allowing me to share. Dr. Gupta?
Lamara, each time I hear your story, I'm in awe of what an inspiration you are. And despite all the challenges that you've had in your life, you're still going about your business. You're spreading awareness about the brain aneurysm. So I thank you from the bottom of the heart to do that. Let's start my talk today. I'll be talking on brain aneurysms. Now, it's a very good time to have this talk. Most of the medical advice that comes on brain aneurysms, it is on the basis of the research that we've done over the last 100 years, probably. They were still clipping aneurysms in 1920s and on. So now there is, most recently, just in July, those guidelines were updated, and I'll share my screen with you. And even though parts of my talk are from my last talk that I had, but I think that the newest guidelines, what I've added and updated, can you guys see my screen?
Yes.
Okay, so newest guidelines have just come out. So the previous talk that I gave was on the basis of 2012 guidelines. And it's a very good time to talk about the newest guidelines, and I've incorporated that in the talk. I've tried to keep it to a level that we can all have a discussion about it, but at the same time trying to update it. So I'll share my screen in a format. So we're going to be talking about brain aneurysms. I've dedicated my life to this profession, and especially brain aneurysm. In the last 10 years, I don't do any brain tumors, no spine surgery, because our brain aneurysm program here at Robert Wood, we're a multidisciplinary program that we run here. Not one physician knows it all. We're a group of doctors from different fields which cater to brain aneurysm. I'm from neurosurgery side. Dr. Roy Chaudhary is from the interventional neuroradiology side. Dr. Haisan is another neurosurgeon. Dr. Imad Noor is from the neurology side. And we have an excellent neurocritical care, Dr. Kiwan Lee and of his neurocritical care colleagues from the stroke side. So it takes a village, just like it takes a village to raise a child. It really takes a village to get a patient with a brain aneurysm through this journey that they have. Now, a lot of patients are unfortunate to make through this journey. So that's why I think let's start with talking about brain aneurysm so we get a basic idea. So all the blood that travels through our body actually travels through pipes. These pipes are called arteries. And when, for example, this garden hose, when there is a weakness of this particular pipe, then that weakness is called an aneurysm. For example, if this is a normal pipe that I'm drawing, and that pipe becomes weak from here to here, that forms a bubble. And that bubble, just like that, that's called an aneurysm. It can form anywhere in the body. Anywhere there where there's a blood vessel, you can form an aneurysm. When they form in the brain, that's called a brain aneurysm. You see that it's like a tire bubble on the tire of your car or a bubble on the garden hose. Let me X out of here. Okay, let's talk about some statistics. Brain Aneurysm Foundation has a very nice page on the statistics. I was able to update them on the basis of the 2023 guidelines. So 2% of the US population has a brain aneurysm. For example, I can see there are almost 100 people in this room. And if there were new people who don't know they have brain aneurysms, 2 out of every 100 will have a brain aneurysm. That roughly is about 6.7 million people. And out of that, it's not that every single one of them is going to rupture. So out of the 6.7 million, only about 30,000 people per se have a rupture each year. And majority of the patients that I see in my clinic, I'm glad they're diagnosed, but 50 to 80% will never rupture. One brain aneurysm ruptures every 18 minutes. That's pretty sad. Women in general have a slightly higher risk of rupturing, about a 1.5 times higher risk than men, and African Americans and Hispanics are twice as likely to have them. If a brain aneurysm does rupture, it's fatal in about 50% cases. So the best treatment, if it is indicated, is before it ruptures. And out of the ruptured aneurysms, the other 40 to 50% that survive, despite treatment, a majority of them will have permanent neurological deficits. In fact, now this is a new thing in the 2023 guidelines there. In the past, this number was slightly lower. And now they've actually put the number as 26%, 20 to 26% people will die before reaching a hospital. For example, grandmom or grandma was found down in the kitchen. We have no idea what happened. Oh, maybe she had a heart attack. But now with the medical advances and our EMS crew being very good at it, we know that a lot of those patients may have had brain aneurysms. In the ER, if any patient who presents this there, I suppose there are 100 patients that an ER physician sees, between 1 and 4 out of 100 will have ruptured brain aneurysm for headaches only. So it's not the commonest cause of headaches, but it's certainly the most dangerous cause of headaches. 20% people have more than one aneurysm, and we'll talk about that as well. As Lamira said, they can be silent. Patients may not know that they have a brain aneurysm, right? It can certainly, the symptoms that you get from a brain aneurysm is mostly when it bursts. Even in unruptured patients, patients can be symptomatic if the aneurysm is big enough to put pressure on the arteries and nerves. And that's why you get some headaches from the brain aneurysm, or something we call third nerve palsy. For example, if the aneurysm is pressing on the nerve that goes to the eye, you may have symptoms from that. 50% people have never hospitalized. We talked about the mortality. We talked about the morbidity, and only 25% return to work. Lamira is, as I said, she's an inspiration that she continues to go back to work and has again reached the top of her career, and at the same time spreads awareness about brain aneurysms. This is directly from the cartoon, directly from the new guidelines. It talks about the phases of care. It talks about the patient-centric management, and I'll go touch each of them later on in the talk about what is done before, what happens in the ER, what happens what is the treatment. Here's the example of the clipping of aneurysm, coiling of aneurysm, post-care, outpatient care, what is early brain injury, delayed brain injury. We'll talk about all those, but this is a cartoon just from that. The article is freely available on the web from American Heart Association, Stroke Association. Okay, so we know a patient has brain aneurysm. What are the risk factors? Hypertension and smoking by far are the biggest risk factors that make the aneurysms grow in size and potentially bleed. So whenever a patient who has brain aneurysms, we see hypertension and smoking, we counsel them a lot to give up smoking. We know what smoking does to the lungs, but directly for brain aneurysms, it is directly related to increasing in size of the brain aneurysms and increasing the rupture risk as well. Other than that, larger aneurysms, they tend to rupture more easily than smaller ones, but that does not mean that smaller aneurysms don't even rupture. Small Chihuahua dogs do make noise. So in this case, it is based on everything put together, not only the size of the aneurysm, but patient characteristics, whether the patient himself or herself has had an aneurysm in the past, are there family members who've had brain aneurysm ruptures, et cetera, et cetera. There are some genetic syndromes. For example, autosomal dominant polycystic kidney is probably one of the strongest ones, that if some patients who have family history of kidney disease, especially the autosomal dominant polycystic kidney disease, we screen them for the brain aneurysms. Ehlers-Danlos is another example. All right, what about family screening? So routinely, we do not recommend any, if you have a headache, that you get a brain scan. No, only this family screening is indicated if there are 2 members of the family within one family who have brain aneurysms. Then we recommend family screening of all first-degree relatives. What are the chances? This is a newer 2023 recommendation. What are the chances that any member of the family have a brain aneurysm? If 2 members have it, is about 12 to 15% chance that member. Then that's why we need to screen these. What is a screening test? It's an MRA, and we'll go to that. Another new thing that I picked up in the recommendations is that, so you've got 2 family members, and now we've scanned, let's say, a brother and a sister also, and it's negative. Are they done for life, in the sense that do we have to scan them again? So the recommendation now is scan them every 5 to 7 years for individuals between 20 and 80 years of age, if they have family history of 2 members of the family. So there you go. I was personally not recommending that, but now I'm going to recommend that even if your MRA, family members' MRA is negative, it needs to be repeated 5 to 7 years. How can we prevent rupture other than treatment of hypertension and keep the hypertension in control and smoking cessation? We generally don't have any other way to prevent a subarachnoid hemorrhage. I'm sorry, when I say subarachnoid hemorrhage, that is equal to a ruptured brain aneurysm. So SAH, when you see on this screen, it means ruptured brain aneurysm, subarachnoid hemorrhage. This is the same thing, class 1 evidence that hypertension to be treated and tobacco smoking. What happens after you rupture? So we only see patients who have rupture, who stop bleeding. If the patient continues to bleed when they're at home, we don't see them. Those are the people who actually pass away. The patients we see are the ones which have stopped bleeding, and the whole idea of this is to prevent a rebleed and to take care of the complications that occurred from the bleeding. So what are the predictors of good or poor outcome? Is what we call Hunt and Hess grade. You don't need to remember it. Basically, it is your clinical status when you present after rupture. If the patient is awake and alert, grade 1 patient, they're gonna have a better outcome. If by the outset a patient comes in a coma, they're going to have a tough time getting out of that. So the initial severity of clinical presentation is one of the strongest predictors of how the patient will do. Aneurysm, remember we just talked about that we're trying to prevent a rebleed. Let's talk about the initial bleed. The initial bleed is only about 1 second, maybe 1.5 to 2 seconds. And only a small amount of blood comes out, maybe 1 cc's, 2 cc's, 3 cc's. That's it. And the body is so beautiful that immediately we shut down the aneurysm. The body itself, the chemical changes that occur, they put a plug on the hole from where the blood came out. And our entire idea of the brain surgery or treatment of these brain aneurysms is to prevent a rebleeding, because aneurysm rebleeding here is a major predictor of poor outcome. That's what we're trying to prevent here. Other things, older age, older patients may not do as well as younger patients do. Other comorbidities, cerebral edema, vasospasm. We won't go into details, but all of those are also responsible. Let's look at the anatomy a little bit. This is how our body is. This is how God made our bodies. There's a heart here, and that heart is a pump. It pumps the blood to every organ. There's an I-95 in the center of the body, right here. So every blood vessel is connected to each other. These are the two blood vessels which go into the brain called the carotid arteries, and two blood vessels in the back of the brain called the vertebral arteries, which we will see in a minute. But these are the main big blood vessels going to the brain. When they reach the neck here, this is the neck, and they go into the brain, this is what it looks like. It bifurcates into a big blood vessel called internal carotid artery and an external carotid. The external carotid artery is going to basically your face and your other parts of the scalp and whatnot, and the internal goes into the brain. You have two of them on the left side carotid artery and the right side carotid artery. So think of them as a Lincoln tunnel and a Holland tunnel. We will talk about that. Just like Manhattan is supplied by many tunnels and bridges, so is our brain. So just because a Lincoln tunnel has shut down, that doesn't mean Manhattan doesn't have traffic anymore. Yes, the Holland Tunnel and the Brooklyn Battery Bridge, they're going to have more congestion, but still everything keeps going. So similarly in our brain, we have this network of blood vessels, which really call the circle of Willis. So only a small number of people have the intact circle of Willis, but this is your Lincoln Tunnel, Holland Tunnel, Brooklyn Battery Bridge, Williamsburg Bridge, and Whitestone Bridge. So entire Manhattan here has a you can have your West Side Highway here. It is a complete circle. Not every patient has a complete circle, but it is a good idea to show this to you, to show that just because one blood vessel shuts down, that doesn't mean that there is no blood going into the brain at all. For example, in this patient, you can see this is an MRA. In this patient, you can see that the from the left side, if you call this the West Side Highway, this road is either not there or is very small, but the other ones are pretty big. So everything continues. We won't go into this in detail. This is the structure of the blood vessel, how many layers they have. All that needs to be known is that when this blood vessel becomes weak and forms a bubble, that's an aneurysm. Why is it called a subarachnoid hemorrhage? That is because if you look at the skull, if this is the outermost layer, which is the scalp, and then is the skull, then is the covering of the brain called dura mater. Under that is another covering called arachnoid. Under that is the pia mater, and then is the brain. And between the arachnoid and the pia mater, that's a big space here where all the blood vessels travel. And if there was a brain aneurysm that bleeds, or any blood vessel that bleeds, that's where it's going to bleed. So it is going to bleed in the subarachnoid space. And that's why the term subarachnoid hemorrhage is equivalent to a ruptured brain aneurysm. Trauma is the commonest cause. Here, this is just a cartoon to show the exact same thing, that the bubble on the tire of the car versus a bubble on the aneurysm. Here's the actual pictures of a brain aneurysm during an open brain surgery. Here's the blood vessel, the pipe that becomes weak. It has ballooned out, and just pretty much similar to this cartoon. And then that's that. How do patients present? As Lamira was saying, the elephant on the chest is indicative of heart attack. When anybody says the worst headache of life, ruptured brain aneurysm is the number one thing. Bleeding in the brain is the number one thing that should come to mind. These patients immediately, anytime somebody says, well, I know my headaches, I've had them all the time, but this headache is different. It is worse. The quality is different. The intensity is different. The location. Patients who have headaches are absolutely able to tell this is not their usual headache. This is different. It must be taken very, very seriously and must be taken to the nearest ER. Does every patient need to come to Robert Wood Johnson University Hospital in New Brunswick? Absolutely not. They need to go to the nearest ER where the CAT scan of the brain can be performed, because if it is any other cause of headaches, then the treatment can be begun. But if it is a brain aneurysm, then we can take care of this. A sentinel headache or a warning headache can be in up to 40% of the people in the last week or so before the actual bigger bleed that is there. How do patients' other manifestations, headache, nausea, vomiting are seen, loss of consciousness, and stiffness of the neck is there. Interestingly, even when patients come to the ER, even us as medical fraternity, we actually make mistakes. And the most common diagnostic error that is made is an failure to obtain a CAT scan of the brain. I can tell you, even 2 weeks ago, I had a patient who went to the ER at one hospital, worst headache of life, was sent home saying that this is your sinuses, went to another hospital, worst headache of life. They're saying you're just being a baby. Okay, here's antibiotics, and went to the third hospital. And then we recognize, oh boy, this is not a regular headache. This is not sinusitis. This is not something antibiotics will take care of. This is a brain aneurysm. So when I give this lecture or similar lecture to my physician colleagues or medical students, in 2023, CAT scans are not very expensive. They save lives. It is minimal radiation to the brain. And if you're thinking about, can it be a ruptured brain aneurysm? Do I need a CAT scan? Just do it. This is a picture of what a CAT scan looks like. Here, the white part is the bleeding. This is skull. And this is what it looks like. It is very characteristic to see a ruptured brain aneurysm bleeding. Now, what happens in ruptured brain aneurysm? The bleeding is now stopped, but all this white part, see, outside this is the skull bone. Well, let's go over what a CAT scan is. Basically, a CAT scan is taking slices, right? You take a loaf of bread, cut it into slices, and look at each slice. That's what we do with a CAT scan. Take the brain, the CAT scanner cut, or an MRI, but in the acute setting, it's a CAT scanner. Cut slices, each slice is 5 millimeters thick, and then you see the pictures. So on the white, the outside white is calcium in the bone, so that's the skull bone. The gray is the brain, the black is the water system. So other than rupture, initial rupture, this white areas right here, all this is brain, all this is the bleeding in the brain. It also shuts down your water system of the brain. These black parts, these are called ventricles. They are the water system of the brain. In a normal person, the water comes in and the water goes out. The amount of water coming in the brain, called cerebrospinal fluid, is equal to the amount of water going out. When this happens, the drains which take the water out of the brain get clogged and everything backs up. And that's what the other cause of death is, acute hydrocephalus immediately. So what do we do in these cases? Even before we repair the brain aneurysm, the patient's going to die from the fluid buildup in the brain, a lot of high blood pressure. We do, just like Lamara said, her hair was cut there. This is what was done for her, that her hair was shaved a little bit here. Then the skull bone was drilled here. We go to Home Depot, see which drill is on sale, and then we just get that drill. Now, we have fancy devices with us. It's not a Home Depot drill. We drill a little skull hole in the skull and put a tube here, here, here. It comes into the water system of the brain, and that relieves the pressure. All right. So what is the first test we spoke about? It's the CAT scan of the brain that we do. And then we have to figure out, after the CAT scan, the next step is to figure out where is it bleeding from. And then you do a CAT scan angiogram. A dye is mixed with your own blood. Wherever the blood goes, the dye goes. And that's why we get the CAT scan angiogram and see, aha, that's where the bubble is. And if for some reason CAT scan angiogram is not as conclusive, we go towards what we call a diagnostic cerebral angiogram, digital subtraction angiography. MRI is only for outpatients where the patient says, oh, it's a mild headache, I don't want to really do it, or as a follow-up. But in acute, when the aneurysm is rupturing or ruptured, MRI is not done except for when we can't find the aneurysm because of some other reasons, which we will go into a little detail. Digital subtraction angiography is the one that we go. And next, what do? We prevent the rebleeding. What is the rupture risk? Re-rupture risk, 3 to 4% in the first 24 hours. So the maximal risk is in the first 12 hours. So we absolutely try to make sure that the faster the patient gets to the ER, that's great. Now, if you come after hours, there are a lot of studies which have shown that long brain surgery in the middle of the night is not good. You don't have your A team, you don't have the surgeon is probably tired. So in that case, we wait until the next day. We keep you in the ICU. We make sure you don't re-rupture, and then we do the surgery the next day. In last 31 years that I've been in the medical field, I can tell you, I can count on one hand or maybe two hands that in the middle of the night, unless the patient is going to not survive the night because of a big bleed and they need open brain surgery to remove the hematoma, we do it the next day. Rebleeding is associated with high mortality, poor prognosis, and urgently, this patient in the ERs with ruptured brain aneurysm can't be the last patient that the ER physician sees. We talked about the acute hydrocephalus, that is the water buildup. And these patients, after a while, they also may need something called a shunt. And that is if the water system of the brain doesn't start back. This is the water system of the brain, like we talked about. The water is coming in, the CSF is being built, and then it goes around the brain, and then it gets absorbed back there. This is the tube that I was talking about called a external ventricular drain. It goes through the skull bone into these ventricles or the fluid-filled spaces there. Seizures, we do put patients on seizure medications, but long-term, if the patient has not had a seizure, we don't continue to have, it's not like you're going to have anti-seizure medication for the rest of your lives, unless the patient does have a seizure disorder. So we don't use prophylactic anticonvulsants at that time. What are the treatments? So basically, the treatment of any brain aneurysm is to stop the blood from going in. For example, I'm going to draw here. For example, if this is the brain aneurysm that you're seeing, this is the actual brain aneurysm. This is where, for example, if it ruptures from, we have to shut down the door right here. This is the actual, all what we need to do. That's with whether you do it with open brain surgery or you do with the minimally coiling. Open brain surgery is done from outside the blood vessel. From here, for example, that always requires craniotomy, which means take the bone off. It's surgery we've done for over 100 years. Even 1920s, they were doing the clipping surgery. That's the clip or a clamp. This is the clip or a clamp that is used. Basically, you pinch off the neck right here. Pinch off the neck. So no liquid blood can go into the aneurysm. If no liquid blood goes into the aneurysm won't re-rupture. Next is when I was finishing medical school in 1990s, 1997, 98, the new technology of coiling. So if clipping is from outside the blood vessel, coiling is from inside, pretty much like a rotor-rooter. As I said, the entire body blood vessels are connected to each other. The Garden State Parkway is connected to I-95. So you just need to take a ramp up to I-95 and you can drive to California. The biggest ramps that we have in our body to go to I-95 is one in the groin called the femoral artery. And the second one is in the wrist. We take either of them. Either of them. And then we deploy metal coils by taking tubes here. We bring a tube inside a tube inside a tube. We get a tube here and we fill this tube with metal coils. And that coils are made of platinum. The platinum, whatever blood touches this platinum, it clots and then this becomes a scar. And that's the coiling treatment. So this is the open brain surgery coiling and the coiling treatment of brain aneurysms. So let's here, let me get out of this window. And okay, microsurgical clipping, long-standing surgery, excellent results. Endovascular, definitely now for certain aneurysms is the way to go. In fact, now institution, we have an endovascular first policy that first, if the aneurysm patient comes, we will all sit down and say, well, can this be done minimally invasive? And only if it cannot be done minimally invasive, then we do open brain surgery. I'm going to graze past the open brain surgery because of the these are pictures. Not everybody wants to see pictures. If there are some members here in the audience who would not like to look at pictures of brain surgery with open brain and blood, this is a good time to look away or close your screen. But I will continue. This is how we do brain surgery. Every single patient, this is open brain surgery. Their head is maintained in this grip device to hold it stable. We don't clip all the hair. That was so 1990s. Only a strip shave, a little bit we do, and all incisions are made behind the hairline. So cosmetically, it's very important for the patient to feel very good about what they look after brain surgeries. We do computer guided before surgery. We plan, for example, this is a real CAT scan, and we plan the surgery here, how many degrees the head is going to be in this direction, that direction, and where is my first burr hole going to be, how will we do open brain surgery. So next step, if this is an example of what the incision looks like, minimally invasive incision here. And then this is an immediate post procedure, like we just finished the surgery, and you can see that the hair is right there. I shampoo in and shampoo out myself. It gives me some sort of a gratification that I've done my best. So shampoo before the surgery, shampoo after the surgery. You can still see the antibiotic ointment there. This is how we start. This is the burr hole that we make. Then we join those burr holes. As I said, if somebody is not comfortable seeing these images, we can actually shut down the screen. This is how we remove the bone flap from there. This is how I get questions as how do we put it back? We put the bone flap with the plates and screws, as you can see here, and we put it back. It's very, very, very strong. This is similar to the first view we get of the brain. We'll graze past that, and that's the aneurysm real. This is the blood vessel. The key thing in both open brain surgery and minimally invasive brain surgeries, we want the blood to keep going to the rest of the brain. We cannot stop it at any time. If you stop the blood, that's a stroke. And at the same time, this is the aneurysm that you do surgery. So that's the clipping surgery. You're putting a clip or a clamp at the neck of the aneurysm to stop the liquid blood from going in. If liquid blood doesn't go in, then the aneurysm doesn't re-rupture. Here's an example. This is an ugly, multi-lobulated, lot of little blisters, and this is after the clipping. You can see that the clip has been placed here. The same pictures here. Let's not go over the video in the interest of the time. So here's before surgery. Here's the aneurysm right there. Here's it has been pinched off with this aneurysm clip. Excellent results. And we leave minimal footprints on the brain. We don't go through the brain if at all possible. We use natural corridors in the brain. We part them, do the surgery, and come out. We respect the brain. The brain can be extremely unforgiving, so we respect the sanctity of the brain and leave minimal footprints on the brain going in and coming out. Let's go to the endovascular option. As I said, when I was finishing medical school, this treatment was really coming about. That means rather than doing open brain surgery, minimally invasive surgery, 3D pictures of the blood vessels of the brain are obtained, and then we go inside. And then we talked about the coiling. So here's the coiling that I was talking to you about. This video is slightly inaccurate, so please don't go into the inaccuracy of that. This is a brain aneurysm at this skull base. This is just to show the concept of the coiling. We take the ramp to the I-95. There's your I-95. We go up into the brain, take exit 9 towards New Brunswick, and there you are. Here's your tube coming up in the brain, inside the blood vessels, and through those tiny tubes, we deploy these coils. These are metallic coils made of platinum, and wherever platinum touches the blood, it clots. So there is a local blood clot that forms. we have to keep the main pipe open. We can't allow that pipe to be formed, the clot to be formed outside the pipe, but inside the aneurysm be formed. This is a trial that came out back when I was still in training, which showed that for some aneurysms, minimally invasive coiling has much better outcomes than open brain surgery. But the challenges in coiling are there. With both clipping and coiling, the problem is you're only addressing the bubble. Nobody's addressing the parent vessel, the pipe that is weak. So what does happen in coiling patients, and we follow them very, very closely with MRAs, is that these coils are pushed into the corner. Nobody's addressed the weak pipe that was the problem, and the aneurysm comes back. The coils get pushed into one corner, and this is called recanalization. This is an example here. As you can see, there's an aneurysm here, and then here the coils are there. Certainly, the whole aneurysm is not gone. You can see the coils in there, and that's why we will talk about what needs to be done. By certainly, since 1998 to now, there is absolutely so much improvement in the technology of the coils, which are so much better. Another coils, other thing that we face is that what the aneurysm looks like. So if this aneurysm is a narrow neck aneurysm, that means that the aneurysm, let's see if I can, if the door to the aneurysm is small here, this is a narrow neck aneurysm, compared to if the door of the aneurysm is big. So if the aneurysm neck or the door is small, these coils will stay in place. They won't fall down. However, if it's a wide neck aneurysm, just like this one, the aneurysm coil that you put, they're just going to come out into the parent vessel, and that's a problem. So in those cases, we do what we call balloon-assisted coiling. We put a balloon up there, and then we pack these coils with the help of the balloon-assisted coiling. If that's not good, this is an example of the balloon-assisted coiling. Sometimes even balloons are not able to push the coils inside. In that case, we have to do a stent-assisted coiling. This is a mesh tube like a chicken wire or a finger trap. Low density, only a couple of mesh wires that you need to keep the coils inside. What is the problem? The problem is now you've got metal inside the pipe. Earlier, the metal was only in the aneurysm, but now you've got it in the parent vessel. So any blood that touches this metal also clots. Each clot means a stroke. We don't want that. So all patients with stents, whether it's a heart stent or a brain stent, need to be on blood thinners. We put aspirin and Plavix are the blood thinners for 6 months to a year, followed by aspirin, baby aspirin for life. This is an example of the stents that we use, different companies, different types, open cell, closed stent. I won't go into that. That is the how we make stents. There was a beautiful video of how we made stent. No, the companies make stent. Here's an example of the coils that are in place in an aneurysm called anterior communicating artery aneurysm. As I said, there are different stents going from low density stents to high density stents. Most recently, what we've been doing is that the number of wires that are there in the stents we're increasing. So not only the stents do a good job of keeping the coils in place, but they're also repairing the parent vessel. And that's where the concept of flow diversion comes in. This is a patient from some time back, and you can see I've made the blood vessels transparent. You can see the stent inside, the mesh tube inside, and the coils in the aneurysm right there. This is an example. Previously you had seen that we went from the groin. We also go from the wrist. This is from the right wrist. Catheter is coming. This tube is now we're actually in the heart. Then we come out of the heart, and then we go up into the brain like that. Here we're going up in the neck, right there, and then this is how we go. This is, you can see, this is the teeth. You can see here we go up and up. So that's how it is done. Most of these mesh tubes, they range from 3 to 4%, what we say surface coverage area, to all the way up to 30%, 35% coverage area. And that's the concept of flow diversion. These mesh tubes, which have higher density, they cause scarring inside the blood vessel. and that scar then strengthens the blood vessel, there. This is the concept of flow diversion. Here's a big aneurysm that is there. We repair the actual pipe, so nothing in the aneurysm. This is, you can see a Chinese, like a finger trap or a slinky, mesh tube, fancy pantyhose, whatever you want to call it. This is 6 months ago. We put this mesh. You can see how beautifully the parent vessel is now reconstructed. Here's another aneurysm right there. We put 2 telescoping stents inside each other, and then you see this is a CAT scan under there, and telescoping stents. And then 6 months later, you see excellent reconstruction of the parent vessel. The other blood vessels that come off are continuing to come off there. So there are many different types of flow diverters. Pipeline is a flow diverter, and study after study after study has shown the superiority of the flow diversion. That is the latest what we do. I've done about 900 of these jointly with Dr. Roy Chaudhary. We have the largest brain aneurysm program, certainly in the state, but one of the largest in the countries. And we have been very fortunate to have such a large experience, probably close to 900 flow diverting cases that both Dr. Roy Chaudhary and I have done. Here's another example of previous aneurysm that was coiled in the past. It recurred. So that's why I say these aneurysms come back, and it's very important to follow these with serial MRA. Our patients get a yearly MRA. We have an excellent program to actually follow these aneurysms and catch the ones if they are before they can re-rupture. They can certainly re-rupture. It's not that okay, now we've gotten treated, we don't need to ever follow them. This is the newest of those devices called the Surpass Flow Diverter. This is my friend who was the inventor of this device, and great. Again, many different stents have come into the market. This is not in the United States because not FDA approved, but these are not available in the US. But I just wanted to give an idea of the newest devices. Technology changes every year, and we're very fortunate it's available to us in a comprehensive stroke center. Here's the newest of the devices. It's sort of fancy coils. This is a endosaccular device. That means it's a web device which goes into the sac of the aneurysm itself, and then we repair. Here's where us physicians don't agree. Some physicians say it's enough to put these coils and just a web device, and that's it. Don't do anything else. We are of the belief that the parent vessel also needs to be fixed. So that's why we advocate that with the web device, we do the stent also. Here's what beautiful engineering. As you can see, these are wires which have been woven together, just a fancy thing that goes in the coils. And then we detach it electrolytically. We enter from the groin and go up all the way into the brain, but then we electrolytically detach it there. I'm going to stop here. We're out of time here. We do have a very nice brain aneurysm support group. We meet with each other. We take care of each other. I learn a lot, just like you guys heard Lamira speak, and I still learn and continue to learn from my patients. They are the book that I call them my book, which teaches me what challenges they're going through, how to they ask us questions. We bring speakers in our support groups. For example, pharmacologists who say, "Why are you on aspirin Plavix? What to do?" Then we get speakers on what about physical therapy? We get speakers on I need to apply for disability. So this is a great. I think some of the members of our support group may be here on this visit. So it's a very good group. We have teaching lessons, and I can tell you, each member of my support group, I can pitch them against any other support group. All our patients are very well educated because we give them talks and they research. Why did they get clipped? What is a clip? Why did they get coiled? Why are they taking aspirin, Plavix, Coumadin, Brilinta? So we hold educational sessions very, very often. In fact, we do meditation. And here we requested one of our meditation experts to come and show us how we can actually calm our brain down and decrease our blood pressure. So very, very good support group. That's the last slide I have there. If you guys have any questions, whatsoever, please feel free to reach out to me or to Lamira or to the Brain Injury Association. They've done yeoman's work in spreading awareness. And I thank from the bottom of my heart and our program, the good work that the Brain Injury Alliance, Tom Brady is a dear friend of mine who does, he himself is a survivor, who does extraordinary work in spreading the awarenesses, and you've got your different foundations who do that work too. So thank you for all you do in spreading awareness, and I'll stop here. Thank you.
Thank you so much, Dr. Gupta and Lamira. It was so inspiring to hear your story, Lamira and Dr. Gupta. So much I learned today. So thank you so much for all that information. So I will just ask the one question that we have for anybody who, is pressed by time and needs to hop off. I did put the evaluation link in the chat, so feel free to click on that. But I'm going to ask the one question that we got, Dr. Gupta, and if anybody else has one, you can feel free to put that in the chat now. But the one question we did get was, how would you advise a patient, or actually, Lamira, this, for you as well, how would you advise a patient to advocate for themselves in a situation where medical providers might be saying that it's a sinus issue or it's not something serious?
So this is something we really struggle with. You're absolutely right. As I gave an example of 2 weeks ago, we really had a patient who went to 3 different ERs. We're not there yet. I make it an effort that I give talks and lectures, medical students to ER physicians. Fortunately, at our hospital, because they see a lot of referrals that come from other hospitals, still, even in our hospitals, we make mistakes that ER physicians just say it's a headache. Because you see, out of 100 patients, remember, only 1 to 4 out of patients who present to the ER out of headache will have a ruptured brain aneurysm. So should they scan? So they're also thinking, well, we don't want to alarm the general population that each time you have a headache, you need a scan, because you see it's radiation. Each CAT scan is radiation. So we struggle with this. I think it all goes in all. Personally, if they have a family history of brain aneurysms, or they're smokers, hypertensive, they should discuss their physician that this is what their worry is. Can brain aneurysms be one of the things, and do they really need a CAT scan? I think compared to 15, 20 years ago, we are definitely scanning more and more patients in the ER, but the physicians in the ER are usually very good about distinguishing what a sinus headache is and what can go away with antibiotics and when do you need a scan. But Lamira, this is also a question for you because you've been there.
Yes, well, I think mine was a little different because I was on the brink. But as I've talked to others who have had aneurysms, there are a couple of people here in the Bridgewater office where I'm located that have had aneurysms. And initially, the doctors have said, you just have a headache. They just tend to think, as we said, they think that you have a headache. I would say that, when it comes to getting tested, and getting, if you feel something is wrong, keep pushing it. You got to keep pushing it. Oftentimes our insurance does not want to pay for certain things, but you've got to appeal things. And I know when you have that headache, and it's time sensitive. So it's very time sensitive. So I commend the person who went to 3 different hospitals to get an answer, because if you don't feel that you're getting it from one place, then you need to go to another, because it's your life. And I know oftentimes they just don't want to really believe that there's something wrong, but your body, when something's wrong. And if you're in pain, like that excruciating headache that people have said that they had, then you need to continuously go and advocate for yourself, because no one else will do it.
Yeah, great. Thank you both for sharing both of your perspectives. That was great. So it looks like we don't have any other questions. So thank you everyone for coming. Thank you again, Dr. Gupta and Lamira. We really appreciate it. If anybody has any other questions that didn't get answered today, feel free to reach out to me. I'll put my email address in the chat. And again, if you'd like to fill out that post-evaluation survey, that link is in the chat too. So thank you everyone for attending, and we really appreciate your time, and we hope to see you at the next webinar. So this concludes today's webinar.
Thank you.
Thank you so much.